Good evening, everyone, and welcome to the first instalment of the 2025-26 BSMS Monthly Lecture Series. We're back for the new academic year, so thank you for joining us tonight. My name is Agatha, and I work in the outreach team at Brighton and Sussex Medical School. Before we get started with our talk for tonight, I just want to make you aware that this lecture is being recorded. You as members of the audience won't be captured in the recording. It will only be myself and our speaker, and you will be sent the recording a little while after tonight's webinar once it's been edited and captioned, and the video will be uploaded to our YouTube page, where you can also watch the recordings of all of our previous monthly lectures too. During tonight's talk, if you have any questions which you'd like to ask, you can submit them via the Q&A function, and you are able to upvote questions. So if you have a look out to see if anyone has asked the same question that you wanted to ask, you can give it a thumbs up rather than asking the same question again, and that will help us to see which questions people are really keen on being answered. So we'll have a little bit of time at the end of the lecture to respond to any of those questions. So now I'd like to introduce our speaker for tonight. We are joined by Professor Richard de Visser. Richard is Professor of Psychology at BSMS. He's conducted research in health psychology and public health for over 25 years and has received awards for his individual and group teaching. He is co-author of the textbook Psychology for Medicine and Healthcare, which is now in its third edition. Richard completed a BSc in psychology at the University of Melbourne and a PhD at the Australian Research Centre in Sex Health and Society. He then undertook postdoctoral work at Birkbeck College, University of London, before moving to Sussex. So Richard, thank you so much for being with us tonight, and I will hand over to you.
Okay, great. Thanks, Agatha, and thanks everyone for coming this evening. The only other thing, this is my fault for not sending the updated information, but our textbook's now in the fourth edition, which is good to see. So at least people kind of still like that. And if you end up coming and studying at BSMS, then it's one of the things that that you'll see from week one. In fact, I'll be talking to the first year students later this week and telling them all about our textbook and other kind of resources as well. So my work covers a range of things, all in the kind of the border between kind of health psychology and public health. So I'm in the Department of Primary Care and Public Health, and I do research on a range of different topics and using a range of different research methods as well. So some of it is large-scale survey-based research. So I work with Dry January. I've been working with them for over 10 years, evaluating their campaign, where we have thousands of people following them up over time. And some of it's very small scale, down to the size of like individual case studies based on interviews, and this fits somewhere in the middle. And before talking about what we did and why we did it, the other thing I wanted to point out, which I was just saying to Agatha before, was that this was actually a project that where I supervised 4 of our fourth year medical students. So in their fourth year, all the students do a year-long research project, and they're often proposed by the supervisors, or sometimes the students can suggest them themselves. Well, what we did was we generated this project, and 4 students worked on this in their fourth year. Did their own kind of individual assessments, write up. Then in the summer we did a bit more work on that, and I kind of polished things off a little bit for them, submitted it, and basically while they're in their 5th year, they had this paper published that came out, which was on this particular topic. So what I'm going to be talking about today is our research into patient experiences of remote consultations in general practice, looking at what works and what can be improved. And as I said, this is something that has already been published. So if you're interested, this was in the Journal of Health Psychology, pardon me. And you can see there's my name, but also Chimela, Eve, Vahid, and Leah were the 4 students working on this. And I've just taken a screenshot here because this is what the front page of the journal article looks like, in case you're wondering, or in case you want to have a look and track it down and see what's there. I could actually probably put the link to this in the chat maybe towards the end. That might be something that's useful. And if not, you can have you can pause the recording at this page and take down the details if you're really that interested. Okay, so the kind of background to this, why we wanted to do this study was that we know that in-person consultations have always been part of patient experience. Having that one-to-one discussion with someone to find out what the concerns are, what the complaints might be, to share information both ways, to be involved in decision-making about treatment options, and to the kind of follow-up as well. Having that in-person contact is really important. But there's also been, over time, an increasing use of remote consultations, which I'll just abbreviate to RCs here, which are also sometimes called e-consultations or sometimes telehealth. So before we started doing stuff with using Teams and Zoom and things like that, there was this move to do some kind of telehealth, which was often useful in remote contexts when people couldn't travel, or when people were far away from where the medical care was, or they were temporarily unable to travel, say because of illness. But with increasing uses of information technology, where a lot of people have access to video conferencing software and those kind of things, there's this idea that actually it could make it a lot easier for a lot of reasons and could really facilitate healthcare to use remote consultations much more frequently. And alongside this, there's increasing use of chatbots and other forms of artificial intelligence use in healthcare. So the increasing uses of technology there are increasing uses of technology in healthcare, and people are becoming more used to them as well. It's not such an unusual thing to just have a phone consultation from your doctor or a checkup with a pharmacist or something like that. And reflecting that, and reflecting the increasing demands on the NHS, the 2019 long-term plan that was published by the NHS proposed a digital-first primary care provision. So the idea was that there would be patients would contact their practice, and you've all probably had experience of this, contact the practice and have the choice of a quick initial telephone or online consultation with a GP before then deciding with whom, if anyone, there should be an in-person consultation, or whether there could just be straight away referral to someone else, whether that's to a specialist or to pharmacy or some other kind of service. And the thinking behind this, pardon me, I drank my tea too quickly and now it's seeking its revenge on me. So one of the reasons for this was the idea that it could reduce time and costs for everyone involved. It would mean that patients wouldn't have to travel and incur those kind of costs. It would mean that perhaps if healthcare professionals as well didn't have to travel or didn't need as many physical spaces, physical rooms to work in, then that could provide a more efficient service than providing in-person consultations. And that's the other abbreviation that I'll throw up from here and there, IPCs for in-person consultations. So this was the plan in 2019, was to shift to this system. And then, of course, along came COVID. And all of these things had to change very quickly. And I think we were lucky in a way that we were up to where we were with technology, because it meant that it was possible to expand the use of remote consultations rather than suddenly try to implement them without any kind of background. So there was this acceleration to remote consultations during the COVID pandemic. And then what we had since then was this return to something else. The new normal is the term that's used a lot, but now we are in a different place, which matches to some extent that long-term plan of the NHS. But also in the years that followed, there was a kind of this recalibration, resettling of where we're up to, having had an experience of everything going online, or almost everything going online. How did the pendulum swing back to what's the appropriate place? And when do patients think it's appropriate and acceptable to use remote consultations? And when do they think that in-person is really desirable or essential? So a little bit more of the background. So although some people had some concerns about differences in communication modes, so obviously there are clear differences in terms of what you can see, how clearly you can see things. You can't communicate through touch, for example. You can't feel, whether things feel like they're inflamed in terms of heat. You can't look for swelling and necessarily do comparisons in the same way. You also can't look at a person's responses, the kind of pain responses, if you do touch things and you palpate and see where things are happening. On the other hand, there are some benefits that people might feel, that people have reported from remote consultations, in that because they're not in the same room as someone, they may feel less embarrassed raising certain issues because there's not that kind of face-to-face contact, or they feel less exposed in some ways. And overall, research that was done prior to the big shift to online stuff around COVID showed that remote consultations are as effective as in-person consultations, and overall they're seen as being as satisfactory as remote consultations. So there was some kind of positive news. But like I said, we had COVID, we had to do things in a certain way, then we came out of COVID and things could change a little bit. And so there was ongoing concern, despite research showing that remote consultations can be effective. There was this ongoing concern about what's been called the digital divide. So this is, there are disparities in access to and comfort using technology. So people who are less well off and older people tend to have less good access to the technology that's required. They may feel less comfortable or familiar using that. And that means that certain people may be excluded or may find more barriers to healthcare if we shift everything to remote consultations. Another thing that's important is that remote consultations require what's called e-health literacy. You need to know how to be able to play the game of online consultations. So this concept of health literacy is used more broadly, where it goes beyond just simple literacy in terms of, are you able to read and write and communicate effectively? That's one part of it. But e-health literacy is about, do you know how to engage in online consultations and know about the kind of the etiquette, if you like, and what the procedures might be for following up appointments, for booking appointments, all those different kinds of things. So there's something about familiarity, but it's also knowing the broader rule and technical competence, but it's also about kind of knowing the rules of the game and how to, in terms of e-health literacy, there's things like, well, how do you, if you've only got your voice and your face on the screen, how do you get across something that you really feel that you really want to be discussed? If you're in an in-person consultation, there are things you can do or say or gestures you can use which give a pretty clear indication, like, no, I'd like to keep on talking about this, or I feel uncomfortable about that. And that may be harder to do through remote consultations. Yeah, and as I said, the one about connectivity and e-health literacy may be different among certain groups of people. And the last point, another really important one, is that the ability to engage with remote consultations is also influenced by how easily they can be fit into people's everyday life. So if people are in a workplace where it's difficult to find a private space and they get a call from the doctor at 11 o'clock in the morning, how do they find the time and the space and the privacy to be able to have a consultation about something that might be quite sensitive and is definitely going to be quite personal? So, and there are other barriers as well, some of which we'll pick up when I show the results of our research. So there were these kind of existing positives, which were that these things could work well. There was also an awareness of things where there might be some barriers or some difficulties. So we carried out this research in order to explore some of those difficulties. And we timed it after the COVID kind of restrictions. And we wanted to look at people's experiences before and during and then after, and what they would like to see for the future, and ask them about what they thought worked well, but also where the areas for improvement might be. So we aim to recruit 16 people and to have diversity across age and gender and ethnicity. And our plan was to have 4 women aged under 30, so get that kind of younger age group, and 4 men. And we aim to have 4 women and 4 men aged 40 and over. Sorry, that the aged 40, it wasn't just 4 women aged 40, that should be 40 plus. And we wanted to have at least 4 people with a first language other than English. And what that would allow us to do is to see whether there were gender differences, for example, in familiarity and comfort, whether there were those age differences. Ideally, we would have had a slightly older age group, and also we wanted to see whether language fluency or competence was one of the things that influenced things. So we aimed to get 4 people with a first language other than English. So that's not to say, so we did the interviews in English, so they were able to speak English well enough to do the interview, but that wasn't their first language or the language they were most familiar with. And that led us to see whether there were any language barriers to taking part in remote consultations. And this kind of sample size is on the medium to large size for qualitative research. So qualitative research is where, instead of measuring things and doing statistical analysis, which relies on large samples or demands large samples, in qualitative research, what you tend to do is get smaller groups of people who are in clearly defined groups. So these groups defined by age and gender and by language, for example, and then to look within those small groups and also to compare across groups. And the aim isn't to necessarily produce generalizable findings that apply to everyone, but to take specific groups of people that it makes sense to talk to and really explore their experiences in depth and give them plenty of opportunities in the interviews to explain things in their words. So we didn't have a checklist of question and answer responses. We had some broad topics we wanted to ask them about. What were their experiences? What were the good things? What were the bad things? And what were their suggestions for improvements? And then everything else that came below or after those questions were prompts that reflected what individuals said. So if they mentioned a particular experience they'd had, the interviewees would say, well, could you tell me a bit more about that, about how you felt? Or what would have been a better way for that to have happened? And so we're really interested in how they talk about their experiences and what their suggestions for future improvements could be. And so the analysis really is focused on in-depth analysis of what they are saying, what they're telling us, rather than whether they respond to the questions that we've already decided the answers to. So, and the final sample we had included 17 people. 5 had a first language other than English, and we had a couple of people in their 30s, but we had actually quite a lot of people in the over 40 kind of category. We had quite a few people who are a lot older than that. We did online interviews. We used the automatic transcription function there and then checked that for accuracy. And then what we did was to, as is typical in this kind of research, we made everything anonymous. So we took out all the names and replaced them with fake names. So if I'd been interviewed, my name on my transcript might just become Bob, and it might say Bob 50 something and no comment about my English language. Or someone who was, you might have Emanuela 28 FLOTE, which says that was someone whose pseudonym that was given was Emanuela. She's 28 years old and her first language wasn't English. And as I said, the 4 medical students each analysed their own little subsamples, then we combined them all together and synthesised that for publication. And we used an approach which is called reflexive thematic analysis, where you think about, have to take into account your own kind of what you bring to the research in terms of your own professional role, your preconceptions, like what you would like to happen, the fact that your own gender or your identity might affect things as well. And this approach, I should say, is one that's used very widely. This approach to qualitative research is used a lot in research into patient perspectives because it's a really effective way to find out what individuals want to tell us in their own words, rather than us deciding what the questions and answers might be. And in terms of what we found, there are 5 major themes, and they're presented here as being fairly distinct. I mean, that makes it easy to present in terms of theme when you see the headings on the slides, theme 1, theme 2, and so on. But there was a lot of overlap between them. And what I'll do, as well as naming them here on the screen, I'll then take you through each of those themes with some illustrative quotes from participants about what they said. And some of the themes also have little components within them. So if you look at theme 1, first of all, we had convenience and comfort, and then there was also confidence and confidentiality as two separate themes are there. And I'll come back to the extent to which they're overlapped when we get to the end, the kind of very end discussion here. So the first thing we found was related to convenience and comfort and confidentiality and confidence. In relation to the first 2 of those C's, interviewees really did appreciate the remote consultations allowed them to attain medical care if they weren't allowed to travel, for example, if they weren't well enough. And in general, they described them as being more convenient. So here's a quote, and you can see in the little square brackets at the end. So this is Alice, who was a female participant aged in her 20s. Alice said, "I'm sure that for lots of people who live in more remote areas or are less able-bodied or less able to sort of freely travel, it gives them access to care, maybe in a way that they wouldn't be possible otherwise. And if you're able to just make a phone call or have someone call you, it's convenient. I guess that also applies if you've got young children or if you're a carer or something like that, which might also stop you from being able to go to a clinic or to a GP." So here Alice was referring to her own experience, but also what she'd seen around her, or what she imagined might be happening. That a lot of people would find remote consultations easier because there wasn't that need to travel. The convenience was there, and sometimes the comfort as well. People mentioned things about being able to do things from the comfort of their home rather than going and sitting in a overheated or underheated, noisy, stuffed with other people, full of cough, a waiting room full of other people who were coughing and sniffling all over the place as well. So they felt in some ways more comfortable and safer at home as well. Some noted that remote consultations could also be more convenient for health professionals. So Jamal said, "Well, it saves a lot of my time and doctors' time as well." And Molly added to that and said, "Well, it is better time-wise, and some GPs could do it from home." And mentioned that could probably increase the number of appointments that GPs can offer, which means that more patients can be satisfied with the service. So what it could do is it could reduce waiting times. It could allow appointments to be slightly longer because you wouldn't have that demand on resources and travel time that would be there. And interviewees also liked the fact that some elements of the remote consultation process could be completed outside of typical working hours. So they didn't have to wait until 8 o'clock and sit there on the phone and hopefully be the first one to jump on the phone and get in the queue to book an appointment. A lot of that form filling could be done the night before, so that it would be picked up early on. And And I'm telling you this kind of stuff you probably already know from having done it yourselves before, but that was one of the things that people thought that was good. The bits where you don't have to be doing it at the same time as the person in the office, you can do them separately. And then bits where you need to talk to people, you do that when they're around and when they've been able to work out who they can see and when they can see them. The second part of theme one was about the confidence and confidentiality. And so an additional benefit that was perceived was that remote consultations gave some kind of distance from the GP that made them more willing to discuss sensitive or private topics. So Elizabeth, who's a woman in her 60s with a first language other than English, said, well, I'm a little bit of a shy person. I find that on the phone, I can talk better and explain better my problem rather than face to face to see the doctor. So here it was the idea that distance gave her more confidence. And when she was more confident, she'd explain things in more detail. She could give more information about her condition, which means the doctor would be better informed. I'm filling in lots of gaps here, which would mean the doctor would be better informed, which means that then they'd be able to make more effective decisions about treatment. And some also suggested the familiarity and comfort of home made them more able to discuss sensitive topics. But they also noted this wasn't always the case. So here's Molly again, a woman in her 30s, said, with mental health issues, I wouldn't feel comfortable. For most issues, I think it's fine, but for some, they definitely need to be seen in person, especially for some people. I've felt a few times that I didn't want a phone conversation at my parents' house, so I've actually had to leave the house if it's an uncomfortable consultation. So here's one of those situations where not only was there a preference for some things to always be seen in person, but there are also some situations, whatever the topic was, where if you could be overheard or if you didn't have that privacy, that could be quite difficult to have to do it at home. And in Molly's case, she said she just had to go for a walk, take her phone with her and have that consultation for fear of her parents or other family members overhearing what was meant to be a confidential discussion and what would be a confidential discussion behind the closed door in the medical consultation room. The second theme that came up was around technology and experiences of using the technology itself. And the interviewees described their own experiences as relatively trouble-free, but they often presented this in contrast to other people's experiences. So here's Molly again, who said, as I'm young, I found it easy, but for my mum, who isn't tech savvy, I think she'd struggle. People who are good with technology would be fine with it, but for example, a 75-year-old would struggle. Obviously, one of the things to note here is that we did our interviews online, so we had people who were already happy enough to do an interview online. So we'd already inadvertently done some kind of filtering out of the people who would find it really difficult. But even within that group, people were saying that even though they felt comfortable with the technology, they could recognize and acknowledge that other people might not find that so easy. And that's something that would need to be taken into consideration or acknowledged as a potential barrier, and then therefore think about alternative means for engaging those patients. But whereas Molly mentioned older people maybe being a group that would struggle with the technology, even some of the younger interviewees whose jobs involved using information and communication technology, they noted that not all of these remote consultation processes were easy to navigate. John, who's in his mid-40s and works in a professional kind of office-based location, said that people may not have much money or they might be tech savvy, and he said I could imagine them experiences are quite stressful, uploading pictures, and here he refers to his dad. He says, my dad's 76, he's got Alzheimer's. If they said to him to upload pictures, he wouldn't have a clue about what to do, and it would cause him a lot of distress. There was a little pause here, the square brackets with the dots where they talked about something else, and John himself was saying, I had done this photo, and he said, I asked somebody else to help me with it because I'm not very tech savvy and I get frustrated. So even people who are used to using this, if there's an unfamiliar system or whether they have to upload a photo or something like that, that could be difficult as well. So even people who are okay with the technology may find the specific forms that are used by their practice to be difficult things to deal with as well. So it would be wrong to assume that everyone will find it easy to do, and also that all of the groups would have similar levels of difficulty or ease of using that particular approach. The third theme we looked at was going beyond the technological aspects and the access and those kind of things, and it focused on the doctor-patient communication itself. And one of the things that came up here was around both information exchange and empathy. Generally, most felt that physical proximity and contact were needed to conduct the necessary assessment for proper diagnosis. So Chantel here said, well, he can't even, this is referring to the doctor can't even, assess you physically. The patient needs to be touched. You need to feel the patient. You need to understand where the pain is. You need to do a physical assessment. And that's obviously clear in those situations where there's a need for the physical assessment, but that may not apply in all cases. But you can see in this case, they were saying that you really need, there are some situations where you definitely have to be doing that in person. But in addition to that, whatever the kind of presenting concern was and the examination needs might be, they also noted that perhaps more important was the feeling that remote consultations are, and here's a couple of little one-liner or phrase quotes, less human, and that there's no personal interaction. So at all, Alice in her 20s said this, Keith in his 60s said this as well. They said there is something missing. It doesn't feel like you're having the same interaction with the person. And given that empathy is so important in establishing and maintaining that doctor-patient relationship, and is really essential for facilitating open, clear dialogue about concerns, complaints, and discussion about when things are going wrong as well, that lack of empathy was seen to be a real barrier. Interviewees felt that it was harder for doctors to be empathic in remote consultations. And they felt that there's a combination of in-person contact from in an in-person consultation and the continuity of care meant that doctors really know the patient as a person. So Amy said that she compared the online experience to the in-person consultation and said, when I was in person, he'd say, I noticed that you're looking tired, that sort of thing that can't be noticed when you're over the phone or even online. So having the ongoing relationship plus being able to see someone directly and see how they look, but also how they're responding, that broader knowledge of the person as a person is sometimes really important because it gives a lot of clues to some of the other issues that might be going on. And some of the interviewees said that it was important to be in the in-person consultation, not just because of the interpersonal interaction, but they noted that being in a medical context with all the equipment and all the resources gave them a stronger feeling of confidence. So Bob, who was in his 50s, said, you want confidence in the person that's providing you advice on your care. And I think that's probably easier to get that confidence if you're in person and surrounded by, I guess, all of the paraphernalia at the surgery, whatever it might look like in person than you can do online. So there's the idea that if you go to the place where the medical stuff happens, you know that you're actually getting treated properly in that situation. And if you're not there, it's harder to get that sense of being fully involved in that medical consultation. And there's a slight diversion from this, which we didn't pick on. There's plenty of research as well that shows that there's something about the performance, if you like, the experience of you come in, you sit down, there are certain things that happen. You see a doctor dressed in a certain way, they've got certain equipment around them. Those kind of things have been shown in other research to increase the confidence that patients have in their doctors. And if they're more confident, they're more willing to share the kind of information, they get more involved in agreeing with the decision making or being involved in patient-centered care because they feel like they're being taken seriously by a professional. And some of that could be missing in an online consultation. It was also noted that there were some barriers to communication. So particularly among patients whose first language wasn't English. So these interviewees noted that if they struggled to understand strong accents in in-person interactions, then this was even worse in remote consultations. So Alex here said, the only difficulty for me comes when, as you know, English is not my first language, so I do struggle. And when I'm talking to doctors that also have a strong accent, for example, and for me, part of communicating is reading their lips. So when I'm talking to someone and I'm seeing their face, it's easier for me to understand them if they have a strong accent over the phone. That I'm at a struggle to understand what they're saying. So here, the specific example was talking about a phone conversation, but even if you're doing something that's in a video consultation, if you're doing it on your phone, for example, the screen's fairly small, it might be harder as well to do the kind of lip reading that's required, and also to get the gestures that sometimes are really important as aids to communication as well. However, positively, Alex and others noted that if they did point out these difficulties, then they could be addressed by slowing down, by using accessible language, and by the doctors checking their comprehension as well. And these are things that we'd like to think that all doctors would kind of be doing anyway, but when it's busy, and if the assumption is that someone's understanding things unless they say so, this puts a bit of the responsibility on the patients to point those things out when they happen. And that can't always be easy, particularly if it's a first consultation with someone that they don't know. They might not feel as comfortable. They might feel embarrassed kind of discussing those things as well. So when it came to the communication itself, there were lots of things about the nature of the interaction that affected people's confidence and the sense of empathy and being understood. There were things about the actual physical location as well, and there were things about the quality of the conversation as well. And if you've got a scratchy line, or the image isn't loading, or you're freezing and things like that, people could feel like, you know, as the images or the sound is breaking up, so too might the doctor's comprehension of their needs and their wishes for that consultation. The fourth theme then we looked at was appropriate use of remote consultation. So we saw that there were lots of positives. There were a few kind of questions about when they're not so good, particularly when patients felt that a physical examination was really important. And so in some cases, patients said, yep, it's definitely okay to use remote consultations here. In other situations, they said, no, I don't think I'd feel comfortable with a remote consultation. I'd really want to have the in-person consultation. So the interviewees acknowledged that online form filling and remote consultations are an important part of triaging procedures. They can really streamline things about determining who really needs to be seen in person and who maybe can be consulted over the phone, or who isn't an urgent kind of priority. And the patients were in broad agreement that remote consultations were suitable if the medical concerns were things like, they used words like ordinary or superficial or not severe or not life-threatening. However, they felt that remote consultations may not be helpful when people have ambiguous symptoms, such as referred pain, or for complex or overlapping conditions. And they also mentioned when there was strong emotional content as well. So Elizabeth here said, well, if they need an examination, or maybe if I can't explain what's really my problem, and sometimes you've got a pain somewhere, and actually the pain's actually from somewhere else. So if you were just doing the remote consultation, the video or the phone consultation, and you were talking about where the pain was and you couldn't quite explain where it was, and it's very difficult to show because, you know, how do you get your leg up in front of the camera and point to where the pain is and all those different kinds of things. But of course, in those situations, you need to see someone in person. But also, even if you could see where the pain was being felt, that doesn't necessarily give the picture of whether that might be referred pain from somewhere else or connected to something else that's going on. So a lot of times patients felt like when they really wanted to be examined to find out what they were experiencing as something that was ambiguous or uncertain, then they wanted to be seen in person so that the doctor could do a much more comprehensive or full examination and assessment. But the exchange of information was not the only deciding factor. Some people liked the anonymity of remote consultations, so they weren't as embarrassed, or they didn't feel like they were being put on the spot as much when it was remote consultation. But many responded negatively to the lack of emotional contact for psychological or emotive concerns. So Andrew here said, well, I think that, and he was referring to psychological issues, there should be a level of empathy that it's better to do when it's face-to-face. And he said, it's difficult to say. It's unnatural. It's a little bit like, I don't know, breaking up with your girlfriend over text or in person. It's impersonal. He's saying when it's a really personal issue that you want to discuss, you need to see someone in person. You can't do that over the phone. You need to be able to express yourself fully to that person and to be seen fully by the other person as well. And Faith here said that face-to-face is, and then you got some kind of contrast as well. So Faith said that face-to-face is a lot better for mental health because on the whole, people need to feel the interaction. I feel like the whole personal interaction adds to the reassurance that they're getting, the help that they need, and they don't feel like they're being rushed, or they don't feel like certain things are being overlooked. So you can see here two people saying, yes, the in-person is really, really important. But a one-size-fits-all approach isn't going to work because some people said that they liked, in some cases, the anonymity of the remote consultation. So what we're getting from this is the idea that you can't just say, oh, well, it's emotional stuff, therefore we've got to do it in person. Or we could just say, oh, this is just a simple follow-up, therefore we can definitely do it online. You need to think about what the needs of the patient might be. And also that means thinking about how they could express their needs before the consultation so that you can meet them where they want to be met in terms of the consultation and the communication style and format. But whatever the reason for the consultation, interviews generally felt that they should be given the options that suit their capabilities and preferences. So Molly here said, I think there should be some face-to-face and some telephone appointments and even video calls, but even they will have their own issues with people who can't use technology very well or don't have a good Wi-Fi connection. So again, don't decide for people what to use. Think about what's the appropriate thing for this particular topic with this particular patient, given their history. And that kind of ties in, thinking about their history, that does tie in a bit to the final theme I'll talk about, which is about continuity of care. And many interviewees commented negatively about their experiences of a lack of continuity and a lack of processes that meant that they weren't being seen by the same person. They were being they felt like they're being shifted from one person to the next, whoever happened to be free at that moment. And they felt that this was inefficient, and it also eroded their confidence and their feelings of being cared for. So Andrew here said, well, one problem is patient's continuity. Who do they speak to? Perhaps when they get a call from the doctor. They don't necessarily know who they're talking to. And maybe, again, that information could be provided as well. Who is the doctor that they're going to be talking to? And maybe the choice for the patient as well. Which doctor would they choose? Because if the patient's being seen by a particular doctor, one doctor, and then someone else comes and they have a chat with them, they may not know their background, they may not give the optimal treatment that they would have had. And some interviewees said as well, they said there was this experience of talking to someone and explaining their story and thinking that was where they were going to see that person again. And then the next call comes in from someone else, and they felt like they had to tell their whole story again because there wasn't that efficient exchange of information. And that if there was more of that continuity, they would feel like they were being treated more like a person with a history and a life, and that the whole person was being treated, not just the particular symptoms that were being presented before them. And that's something that comes up not just here, but in plenty of research. Patients do want to be treated as people with histories and with futures, and not just as clusters of symptoms that need to be sorted out. And interviewees noted that remote consultations, however they're used, they must be properly integrated with linked up continuity of care. And they highlighted how establishing and continuing relationships allowed for the development of rapport and for trust and for feelings of being cared for. So Brian explained a situation which was probably common to a lot of people during the pandemic in particular. He just said, I don't even know who my doctor is. I don't know who I have. I don't have confidence in the doctors because I don't know any of them very well. Because for you to have confidence and trust in someone, you should have seen them before and developed rapport with a person and feel cared for them. However, this is very difficult to achieve online. So it's also difficult to open up more about your problems online. And a lot of people, so Brian mentioned this, but others did, they said, well, can't we have the first consultations in person to establish that relationship when you first get in touch with them? Then it's possible to continue that relationship if it's been set up well. But it's very difficult to start a meaningful interaction online and never meet the person in person. And I know people had these kind of things in lots of other contexts during the pandemic. In work context, people would start work and never meet the people they're working with in person. And the change to online working was easier for the people who already knew their work colleagues because they'd seen them, they'd spent time with them in person, they had relationships with them that could be carried on online. And the patients here and in other contexts have said it's hard to establish those relationships, those therapeutic relationships. It's harder to do it online. And so starting like that and only doing online stuff meant that they felt like somehow they weren't being seen as the whole person. So some patients also felt both less visible and less assertive in remote consultations, and particularly if they were feeling less positive emotionally. And they felt they weren't able to assert themselves as much and get their needs met in those online consultations, especially if they didn't know the person that they were seeing. So Alice here, there's a bit of a long quote, but I guess the things are that a main thing to take from this is where she's saying she was feeling low down at a particular time, especially when I was feeling quite low. The phone calls themselves were positive and good. It's just that the outcomes of the phone calls, well, there wasn't really an outcome. There wasn't really that follow-up. That's what the interviewee asked. And Alice said, yeah, I think the care I received during the phone calls was a high standard, and I felt like I was being listened to and something was going to happen, but it feels like maybe I just got lost or something in the filing system. So a lot of people felt like sometimes they had these good interactions, they talked to one person, they never spoke to that person again. So that relationship just was never established and never had a chance to be ongoing. So covered a lot of ground here. I do want to leave a bit of time for questions and comments afterwards. So the so what of this is, I mean, I found it quite interesting just to do the research, but of course we need to do research which is has some kind of value here. And I guess the things to point out here, first of all, is that although the things were presented as distinct, there was considerable overlap between them. And you could see that when I was talking, I kind of got to the end of the one and I was running into the next one pretty quickly. So the interpersonal aspects of the doctor-patient communication, which were covered in theme 3, fed into the experiences of and their beliefs about the appropriate use of remote consultations, which is theme 4, and they were a component of the continuity of care, theme 5. And another example was that the quality of doctor-patient communication was influenced by having a first language other than English, and also whether the mode of remote consultations allowed for visual communication, which was absent in telephone consultations. So the the main thing we would take away from this is to say that people really felt that it was important to have in-person consultations when they felt that they had needs that they really need to express in person, and also when they needed to establish an ongoing relationship with a medical practitioner. And that the remote consultations could be used for things that weren't urgent, or for follow-ups, or for checking in once that relationship and understanding had been established. So the three aims of this study that we had, which I think I laid out at the start, were to explore patients' experiences of remote consultations, to explore their beliefs about how to improve them, and also their beliefs about when remote consultations are appropriate to use. And in response to those things, what we found is that patients did generally have good experiences of remote consultations, and they saw some value in them. However, they felt that healthcare professionals should attend more to patients' preferred consultation mode in general, whether they preferred in person or online, and also their preferences for specific health concerns. And that would demand having some kind of system that allowed people to express their preferences. And patients also emphasized the need for more user-friendly processes, for greater attention to patients' preferences, and for better continuity of care. And that's where I am with my start slide again, so that I know I've come right back around to the start, and you know as well. I can now go to stop sharing my screen, and I'll be happy to take any questions or listen to any comments that you might have.
Thank you so much, Richard. I always think it's such a shame when we're online that, we can't do a bigger group round of applause, but I'll kind of do that on behalf of the audience because we've had some really good questions
Right.
in the chat. So yeah, I was really interested in your talk as well, because I think when I kind of thought about remote consultations, I guess I was thinking a lot of people have really strong feelings about them, like just anecdotally, like conversations that I've
Yeah.
had, but actually like it's quite interesting to kind of think, well, actually, like, they can really help people to make get rid of some of those barriers to access,
Yeah.
right, in a way, in kind of ways that I hadn't considered, maybe because it's not so like relevant to my situation. So it's just
Yeah.
really interesting to think about the different nuances in it, I guess. So thank you
Yeah.
so much for.
And I think also that's a real value of doing the qualitative research as well. People talk about their experiences, and you can quite easily just say, and how do you think that is for other people? And they'll think they've already thought about what it's like because they've seen their mum or their son or their brother or whoever it might be, or they've imagined what, with that quote from John, they've imagined what it'd be like for their dad with Alzheimer's to do it. Like if they're thinking, if I find it difficult, imagine what it must be like for someone else. So yeah, and you can really explore that in the ways that you can't predict what's going to happen when you go into the interview. So it's a really kind of interesting journey, just collecting the data as well.
Yeah,
Yeah.
absolutely. Yeah, really interesting. Cool. Let's have a look at some of the questions then. Um, well, it seems like we might have some sort of budding researchers
Good.
in the audience, because Prish has asked, and lots of people have given Prish's question a thumbs up. As a 16-year-old student, is there any way for me to get involved in the type of research that you conduct?
Um, the opportunities are fairly scant in those areas. I mean, it would be, I guess, if there's research coming up, which is if there are studies that are looking for younger participants, that's one of the ways that comes up. I mean, often through the Impulse. I don't know if any of the people on the list here have access to that or signed up to that. It often has those calls for those things. In a lot of cases, the research is actually being done kind of with and through particular medical practices as well. So there'll often be advertisements, or there might be direct calls that are coming out in those situations. Um, there are fewer opportunities. I mean, for those who are 16 and younger, there are often fewer opportunities just because of the kind of consent issues around individual consent and those kind of things. So the short answer is that there are some. Often they're focused in certain areas. There's a lot less of it in the areas of around healthcare. I mean, I've done a lot. I think when you mentioned earlier about my early stuff was in sexual health research, and a lot of that was focused on school-based research. So a lot of the research is around young people's health and healthcare use actually tends to happen through schools, because most people are in schools or some kind of education until that age. So it's a good way of finding people. So um, and if the question was, can I send you something really quickly that says this is how you sign up for a research study? The short answer is, unfortunately, no, I can't, because we don't have any of those things like that. But keep your eyes and ears open for those things, I guess. Yeah.
Yeah,
And the thing
absolutely.
I guess as well is saying, if you come to BSMS or a lot of other medical schools as well, but BSMS definitely, everyone does their research project in the fourth year, and that's a really good chance to get involved in real world hands on research, whether that's based in the medical school, out in the community, maybe working with community organisations, or whether it's happening in clinics and other medical practices as well.
Yeah, absolutely. And I think so, yeah, something to, I guess, people to look forward to in the future, as you know, future medical students,
Yeah.
right, to get involved in that kind of research.
And I
And I
mean,
guess,
as a student as well, there are often things where there are other student projects, or also the academics and the clinicians in the medical school are often looking for participants in research of different kinds. I mean, I went in last year sometime, and I went and got involved in it was a MRI scanning while you did a particular decision making task. They were looking for people who where my age and gender happened to match what they were looking for. So I'll go in and do that. I'll spend an hour doing that. You get a mug, you get a scan of your brain, you help out with research. So there's quite a few opportunities like that you can do along the way as you're studying.
yeah,
Yeah.
fantastic, fantastic. And I mean, and it's just great to hear from, these young people as well, 16-year-old students who are like, have that curiosity, right? And
Yeah,
would definitely encourage that.
and yeah, definitely. And sorry, I'm just thinking about other. I don't want to shut off the opportunities for other questions as well, but along the way, there are summer research associate, like research internships you can do as well. So there are opportunities within the degree to do like it's an 8-week period, I think, where you're paid to be a research assistant, and that's a really good way of getting hands-on experience again on a real-world research project that's actually happening. Um, yeah, so there are a few other opportunities, and the intercalation year option as well that comes in where you can take a year out between, I think it's third and fourth year, and do a year of a degree in a field related to medicine in some way, but separate from that, and they typically involve a large research project that you carry out as well. So yeah.
Yeah, absolutely. Thanks, Richard. Cool. There's a question from Victoria about I'm not sure if this was something you looked at in your research, but were there any examples where remote consultations led to misdiagnoses or delayed treatment due to that lack of physical examination?
We didn't have specific examples of that, and again within our sample we had people talking about their experience, but that's one of the concerns that's been raised there, and that's the I guess the important thing about having, especially if you're doing any kind of online triage, forms and those kind of things, is to make sure that they're really. And sometimes it feels like, I don't know if you've probably done one, I've done one definitely, where you feel it and you think, haven't I just answered that question? Didn't I just do that? But what they're doing is making sure they're not missing things, or they're also prompting people again to say, actually, now you've thought about that, is that something else you might need to point up? So they would try to make those forms err on the side of caution. And even if it doesn't feel like that, what they would probably want to do, or we'd hope they'd want to do, is to say, if we have any concern that you might need to have an in-person consultation, we'll definitely suggest that because we don't want to miss that. Yeah, but that is a concern. And so that's the thing about anything that happens remotely needs to be sufficiently detailed that it picks out anyone who might possibly need an in-person consultation and to take it from there rather than just think, oh, well, it's probably okay, we'll just let it run because, those errors of kind of omission are really important. Like, failing to do something you should have done if you'd asked the right questions they're the other side of doing things you shouldn't have done. And they can potentially be more, because also, and what it does, I mean, the thing that comes up from here, I presume where the question's coming from, is if people don't understand the question they're being asked or the kind of information they're being asked for, that can be really difficult. Someone might say, have you experienced this? And someone might say, I'm not quite sure what it means, but no, I don't think so. And if they've been asked in a different way, or if it's been checked, or if someone could look at them and see, actually, it looks like you don't, do you know what I mean when I'm asking that? No, what I mean is this. And it's like, oh, yeah, actually, I have had that. And it's like, okay, great. I'm glad we found out that because now it takes us in this direction. So I don't know how common they are, but I think that I would suggest that there's probably an increased risk of that happening in remote consultations. And that's why the questioning has to be really focused and precise. And sometimes maybe it might feel repetitive because you don't want to miss things.
Mm. Yeah, that's a really interesting point. And I guess that's something that maybe can also be like, I mean, I don't know, but like even like a dialogue, right, of like, then maybe at a later point checking like, did you understand the questions? And if there's a lot of
Yeah,
feedback about, a
yeah,
particular practice's online form or whatever, that it could be kind of changed responding to the feedback of patients
yeah,
and stuff.
yeah, yeah.
Cool. Um, so there's another question kind of maybe a bit linked about, I know you talked about empathy, but someone's asked, did patients feel that remote consultations affected their trust in the GP's judgment or competence?
Yeah, that was something that came out. I mean, I should say as well, in the first of all, in the paper, there's a lot more quotes than I presented here. And in the whole data set, there's a lot more quotes than we even got into the paper as well. So that was one of the things where there, and that was linked in. So in other contexts, but also in our research, there were things like satisfaction with the consultation. So did you feel like you've been listened to? And did you feel like the information you'd been given, it was at the right level and you'd had a chance to answer questions, those kind of things. So more satisfaction with the communication and more of a sense of an empathic connection from the doctor. So if you think that the information has got across, but also the personal relationship has come across, that increases satisfaction. When people are more satisfied with the consultations as it's happening, they're more likely to give information because they feel comfortable and confident doing that. But also, if they're more satisfied, that tends to lead to better adherence to the treatment decisions as well, because you feel like I've been heard, right? They really understood what's going on. I understand why they're telling me that I've got to cut down this or do more of that, or why I've got to take these pills twice a day, whatever it might be. And the more that people feel like they've been heard and listened to and understood, the more they do trust the doctors. The trust and rapport really go together, and that's why it's a really important thing about our students at BSMS are doing stuff around communication skills from kind of week one, year one, because it's about learning that here are the things that you're doing already. Great, keep doing them, and I'll tell you why it's really important to do them. And here are the things where, what you could do in that situation is do or say this because it's likely to have this effect. And it is all about developing and establishing that relationship, which is about feeling understood, but also having that trust in the practitioner and the confidence in that as well. And I think that there are a few times when it came up here. Sometimes it's even about the location. So what people wouldn't want to see it, and there's plenty of research that talks about even how doctors are dressed and those kind of things. But there are people saying if you saw someone at home and they're kind of sitting there in their pajamas or something like that, that's your doctor having a chat. It's kind of like, are you taking this seriously, or are you just kind of you only just got up? Are you really? And the other side of that was the quote from, I think it was, I can't remember who it was, but it was saying when you go in there and you're in the room and you can see, and they've got a stethoscope and they've got they've got all the machines, all the equipment they need. It makes you feel like you're being taken seriously. And in medical consultations, but also in a lot of alternative therapy practice and that kind of stuff as well. A lot of the I've put performance in quotation marks, but a lot of it is the performance of caring for someone. And if you do all those things around, well, I'm going to do this, I'm going to sit here and we're going to have whale sounds playing and all this kind of stuff. They're the things that set the scene. And in the case of a medical consultation, it's about shut the door and you're in a kind of private space and you can see there's no personal stuff with the doctors lying around there. It's all tucked away. They've got the files up there. They've prepared themselves properly for it. All of those things as well increase the trust as well. So there are some things which you just can't replace in the online consultation. And so it's important to think about how do you maintain that trust or establish the trust when you don't have all these other cues around that. You don't have the physical cues in the same way. So it really comes down to a much better, much heavier emphasis on the quality of the communication, because that's all you've got really, is about what's being exchanged on the screen, ears and eyes at that time, not all the background stuff, particularly if you've got fuzzed out background as well here. You can't, yeah.
Yeah, absolutely. Or yeah, a pretend
Yeah, yeah,
background like
exactly.
mine.
I trust you. I was going to trust you. You're from the medical school.
No, I am standing in the sunshine outside the medical building at the moment. Um, no, absolutely. And there's another question actually from Messina, which I think links in nicely about they ask how should doctors respond to these problems that the interviewees described, and should specific training be offered to doctors? So like you said, kind of maybe they should be trained on that kind of how to communicate those
Yeah,
things in an online space or
yeah.
remote space.
That's a great comment, and we do mention that I think in the paper as well, saying, well, what we've got here is we've got patient perspectives. We didn't hear from the other group
Mm.
that's involved, which is the doctors' positions, because what do they? And also the other thing, everyone else who's involved in the clinic as well. I mean, what's it like for the reception staff, for example, to have their admin load changed and hopefully reduced by not having to fill in forms and spend hours on the phone, if it means they can do that kind of stuff. So, but yeah, it does highlight the need for that. I mean, there's already a lot of training that goes into doctors' communication skills, which is really good. It's also important to say, when I mentioned the stuff about e-health literacy on the patient side, for doing that with doctors as well, for them to realize what patients' expectations might be, what the barriers for them taking part might be. We've started doing some work, and we're about to do, hopefully we're going to get some funding to do more of it, but we're looking at autism aware healthcare, and the things there about saying what are the specific needs of autistic patients in these cases, and our doctors aware. So part of it is, well, autistic patients come in and they have different capacities and different interests and different concerns when they're coming into these consultations, and that's one side of the thing. But also what you need to have, you wouldn't just say, oh, they just need to learn how to express themselves better and everything will be fine. what you need to look at this relationship is to say, are the doctors aware of the impact of autism and how it might affect things, both the physical setting, the need for maybe longer processing time, or for difficulty expressing emotions, or even for interoception, like knowing what your body's doing with your feelings as well. That can be different. And if doctors also aren't aware of that and don't adjust their communication style, then they're missing out on that as well. So it's always a two-party kind of interaction. There's always something we could do to patients to make it easier for them to feel comfortable doing this, and also to think about what can we do on the doctor's side so that they are properly skilled and they have the confidence as well to do this along the way. So this is something that is definitely ongoing, and thinking about what is it and where does it come from. And the other thing that's interesting, of course, is it's like all the new doctors coming through medical school at the moment, hopefully they're getting really good education in this, all this kind of stuff. What do you do with the people? What do you do with the doctor who themselves is 60 something, close to retirement, thinking, why do I have to learn all this new technology stuff? I'm retiring soon anyway. Why can't people sort things? There may be barriers there to some, and it may not just be age, it could be due to anything, but you might have those barriers on the doctor side of things as well, about them not understanding that things are always going to be changing, and there's a need to kind of keep up with that, because otherwise the quality of the patient interaction and patient care is going to suffer.
Yeah, really interesting to think about it from the doctor's point of view as well. Like I hadn't I hadn't actually
Yeah, yeah,
considered that.
yeah.
Do you have any plans to like research it from that point of view at all?
Well, there's the work I mentioned around autism. We're hoping to
Mm.
start doing something with that next year. But it does actually, presenting this is always good when you kind of present things and hear questions. You kind of go, yeah, actually that is something you should probably look at as well. So maybe that's what we can start having a look at next, just to see more about the doctors' kind of perspectives on this and their perceived needs for training and those kind of things as well. And to see, yeah, what it's like. I mean, I guess we'd need some time for doctors and patients to have that experience of, okay, now we're in a situation where we don't have to isolate for COVID reasons. And we've had a few years of looking at these things. Where is it really working well? Where is it not working so well? And just to get the right balance between it, because remote consultations aren't going to go away, and in-person consultations aren't going to go away. And it's finding the right balance, like when is it appropriate to use them, and not just to say it's always appropriate in this situation or for this kind of concern or complaint. It's not always this person likes doing this. And it's also the case that it's not always just, you would have doctors who are like, this is an in-person doctor and this is an online doctor. That's not going to work either. And also within that is there are some differences in terms of how happy people are, using all forms of technology, like even things like using, chatbots and that kind of stuff. And then the access to information as well. I mean, probably with a lot of younger patients or more tech savvy patients are probably searching around, finding more information online, and maybe better able to find reputable information, or maybe a lot of people are looking for information online that they take into their doctor that's a load of rubbish or is actually misleading. And then how do you deal with that? Because people are saying, well, I read this here, and it's like, you do know that that's unreliable information.
Yeah, Doctor ChatGPT.
Yeah, 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 yeah,
Oh, well, thank you so much, Richard. I think we'll wrap it up there because we're nearly at half
yeah,
past.
yeah.
And what I'll do as well is I always send an email out to the people who attended, so I can link the full article when I send that out, so people can have a read of that in their own time too.
Great.
Um, so just thank you so much. Yeah, I found it really interesting. There are really great questions that we unfortunately didn't get time for, but
Yeah.
yeah, thank you so much, Richard.
Great. No worries. And thanks everyone for your time this evening. Thanks for turning up. Over 100 people. You made me feel good.
Yeah,
Yeah.
amazing. Thanks, everyone.
Thanks.
We'll finish there and hopefully see you at the next one. Bye.
Bye.